Thanks, Rob. Hey guys, Dr. Joel, the Stress Recovery Ninja. Today I want to talk to you about MTHFR and reoccurring miscarriages. Something that we deal with every single day. And this is an impromptu Facebook Live. I'm going to see if I can get my buddy John to come on here, Dr. John Thomas, and we can talk to you today about MTHFR and reoccurring miscarriages. I have consults every day. Really, I have consults every day about this, and we talk to people about why they are more prone to have miscarriages, and there is an MTHFR component, and that's why they put folic acid in prenatal vitamins. They found that when you fortified vitamins, you were getting less miscarriages or less spontaneous miscarriages. However, with that being said, you were also weakening the gene pool. A lot more autism, a lot more spectrum, a lot more immune problems, immunodeficiencies. And what we've learned now is that the MTHFR enzyme is not effective at converting into a natural methylated folate, which is necessary for you to be able to create energy so that you can gestate and you can birth a baby and grow another human being in your body. Hey, Dr. John, how are you?
Hey, how are you?
Looks like you're good. It looks like you're gonna fall off sideways. For some reason, your thing is turned sideways.
I don't know why that's doing that either. So, all right.
That's okay. So what I wanted to talk about today was I had a couple of consults today, and I'm sure you have them all the time. Like, hey, what's your main concern with your health? And they'll say, listen, I have reoccurring miscarriages.
Mm-hmm.
And so it just gets on their radar that there's this MTHFR just today, like their primary doctor, their OB, which was a very highly specialized, highly referred doctor, and they felt it was necessary to run a MTHFR profile, just one gene, MTHFR, and said, yep, you got it. All right, we'll see you later, let's get you on methylated vitamins. And I asked her, what was the purpose of running these tests? And she goes, I don't really know. So I guess what I wanted to do today was, hey, I just texted you. Are you available real quick so we could jump on the line and talk to people that are dealing with reoccurring miscarriages that have no idea what the whole MTHFR component has to do with it? And what would you explain to them and how it's related?
Yeah, so absolutely. Every single week, sit down with somebody where primary concern or reason they're coming to me is because of recurring miscarriages. And without a doubt, MTHFR and other genetic components are players in this at some level, and it's kind of crazy where it's like the OB or the specialist OB will run these and then say, oh, you just gotta take more folic acid. It's like not. And here's the scary thing is I've actually had some patients come to me because they researched on their own and found out that MTHFR could be a factor with reoccurring miscarriages, and they've actually asked their OB, can you run this on me? And based on like the insurance guidelines, it's like you have to have 3 miscarriages before insurance typically is going to cover an MTHFR genetic test, which to me is crazy. So from an MTHFR standpoint, it is relevant. And we know, when you're talking about MTHFR and really the ultimate goal of what MTHFR does is to produce methylfolate to go into the methionine cycle. And really the ultimate goal is to produce SAMe. Okay. And SAMe's initial priorities is to make choline and creatine. Okay. And so really where the problem lies with MTHFR, I think with the pregnancies, especially with reoccurring miscarriages, not so much the need for, hey, we've got to get methylfolate in the mix, or we got to do high dose methylfolate, which yes, that's important. But the bigger piece I think is the need for or the demand for choline and creatine. I think that's where the big issue with MTHFR and pregnancy and recurrent miscarriages lies, because the biggest deficiencies in pregnancies is in folate. It's not folic acid, it's not folate, it's not methylfolate. It's actually things like creatine and choline, specifically choline, that are huge factors and huge deficiencies through pregnancy. We know that choline is vital for brain health and brain development of the developing fetus. You need the choline for every cell wall in your body. And so if somebody goes into it with an MTHFR defect and possibly some other genetic issues with choline metabolism, they, even before pregnancy, are maybe walking into this with a little bit of a choline deficiency. And now when there's more of a demand on methylation activity for more choline for a developing little one in the womb, that's where a lot of the problem lies. And then other big factors I see with recurrent miscarriage goes back to some other things we've been talking about the last couple of weeks about the iron. The iron transport component. So I'll see a lot of females where they're getting their thyroid and their iron markers or their hemoglobin levels checked on a regular basis because maybe they're anemic prior or they've had a history of anemia. And so some of these solute transport issues or how people can transport iron from inside to outside the cell are big factors with reoccurring miscarriages. So a lot of times when somebody comes in, and they want to get pregnant again, but they've had recurrent miscarriages and they're coming to me because of MTHFR. It's like, well, let's throw the brakes on. Okay, that is a piece of it. But if it was as simple as just, taking more folic acid or taking methylfolate, a lot of the OBs would know that that's kind of a slam dunk in terms of, yes, you got the MTHFR, this is what we're going to do about it, and we've kind of fixed your problems with the reoccurring miscarriages, instead of really kind of understanding what that MTHFR means. And really what the ultimate goal of methylation is to produce SAMe. And about, depending on the studies, 50 to 70% of your SAMe, that your B vitamins, your B9, your B12 goes to make that SAMe, 50 to 70% of that goes to make choline and creatine first. And then whatever's left over is going to make antioxidants, make neurochemicals, and everything else. So choline and creatine is pretty darn important. And then when somebody's pregnant, there's even more of an importance for those nutrients during, as well as after the pregnancy.
Yeah, a lot of great points you bring up there. So the thing that I think always resonated me with Dr. Lynch was his initial philosophy or his mission statement was to impact the health of the unborn child, right? And so when you talk about someone who has reoccurring miscarriages and they're really wondering, okay, what do I do about this? I'm fearful of getting pregnant again. It's a burden for dad and for mom because we get really emotionally involved with the birth of a child, and only to be disappointed again and again. And really what we're saying right now is it's great to look at the methylation component and understand maybe where the weak links in the chain are, and being able to recommend choline, phospholipids, and creatine. But at the same time, we want to know, what is the traffic like on the highways according to our analogy so far? Mm-hmm. Or what are the major accidents on the highways according to our analogies right now? So meaning, how are what's your nutrient status, and what kind of dietary intake do you have, and what kind of microbiome do you have? What is your blood sugar levels, and what kind of communication, what kind of immune system communication and challenges and inflammatory storms that you have right now? What's going on with your stress levels? How's the liver working? So maybe take us through, if someone contacted you or they said, hey, listen, I don't want to have any more reoccurring miscarriages. I know you have the genetic component in front of you that you're looking at right now, or even say you didn't. Let's say you didn't. How would you work that person given the tolls on the highway, the nutritional status, the substrates, the amount of cars on the highway, and the car accidents or inhibitors, or even things that speed up the highways? How would you look at that for the person that is considering having a child again, but they've had reoccurring miscarriages?
Yeah, and when we're talking about, the recurrent miscarriage aspect, we get into the genetic aspect in terms of the pathways that indicate, specific nutritional deficiencies that are there. But, the traffic component is huge because we know a lot of these things like viruses, Lyme disease, metals, they can cross through vertical transmission. And this is starting to be shown in the literature that, if mom goes into it, with a Epstein-Barr virus or a, chronic Lyme component, that's something that can be passed through the fetus. And are those highways triggering effects for the miscarriage to happen in the first place? And so, really, understanding history in terms of, what are the stressors on your system throughout your lifetime to be able to handle that. And maybe to consider, like, if you've had recurring miscarriages, before you kind of go down that road again, is looking at the genetic side of things and optimizing those components. Because the easy thing to do is say, all right, here's a pregnancy protocol based on your genetic predisposition, based on the usual suspects that are deficient through pregnancy. And this is how maybe we got to change that through each trimester. But sometimes the problem lies in some of that traffic, some of those triggering effects on there. And so then you maybe have to kind of put the hold on that for a short period of time to maybe do some things a little bit different, because you're not going to really maybe completely be able to get that virus out of the system or be able to, get metals or chemicals out of the body. So there's that thing of, there is going to be something that's going to be passed, but it's really creating a more balanced environment for yourself as well as for the developing little one that is going to take away as many of the stressors through that pregnancy, so that you're able to go through a pregnancy and, have a healthy child. And then, from there, then the real, work starts in terms of, okay, now what do we got to do to maybe support you after the pregnancy, but then also your new child, knowing some of the stressors from a genetic predisposition, as well as, those stressors that may have been passed down. We're seeing, in terms of, kids on the spectrum, huge increases in the statistics. I think by 2032, they're expecting 1 in 2 kids to be diagnosed on the spectrum, which is just crazy. And a lot of it comes down to is each generation, the genetics look a little bit weaker, and there's more of these stressors or these things that cause increased traffic that's being passed down through vertical transmission. And people aren't understanding that, hey, maybe we got to address our biochemistry a little bit different so that we can handle the traffic flow. It's almost like we're putting a traffic light or traffic cop on that area of the highway that's really helping organize the traffic through, so that there's not these big significant impacts that happen, like the recurrent miscarriages that happen initially. But when people come in my office, this is a huge thing that keeps, happening, and they're, looking for answers, and there's some simple solutions to investigate and do a little bit different for them.
Yeah, and you talked about a great analogy the other day, in terms of in the body, almost think of it as a sci-fi movie. It's really amazing in terms of what the immune system has to do and what the pathogens can do to divert attention away from them, so that your immune system's tricked to not know or go and check out a rogue missile that was set off in another direction, only to elude your immune system, so that a pathogen can maybe shed its cell wall, go inside another cell and be hidden. And really what you said, which was good, is it's a verb, and that it's really who's controlling who. Is your body able to turn off the expression of a virus and keep it in purgatory and be able to have it locked up? Or is the virus able to continue to trick your body and put out a Scud missile and send you in the wrong direction? And really, that's what we're talking about a lot of the times with optimal methylation, optimal production, in this case, for a developing baby, SAMe production, so that you can regenerate your DNA, because SAMe is necessary for regenerating your DNA bases, so that you can repair your muscle and build muscle, and so that you can improve your membrane status, so nutrients can bind and signal a message to the cell to say, okay, let glucose get in, and let the chimney open up so that the smoke can get out of the cell. And if all that stuff is not happening, then reoccurring miscarriages are very, very common. So we'll see a lot of people that are in different stages. Hey, I got pregnant, and this is, what do I do now? So I guess maybe answering that question, John, let's say now someone did get pregnant, and you want to make sure that you create the most fertile environment for that female, so that she stands the most or the optimal probability of delivering a healthy baby, but not pushing cycles too hard with too much nutrients that open up energy producing pathways in the body. So I guess the question, to keep it simple, is what do we do with someone who's had recurring miscarriages in the past that presents to you as being pregnant, and you see their genetic profile in front of you?
Yeah, and there's definitely a demand on the body for some of those, key nutrients, like the choline and the creatine, because there is more of a demand with each trimester. And you're absolutely right. You're not going to want to overdo with nutrients. And so sometimes, like if there's an MTHFR defect, and maybe the answer is not loading up on more methylfolate, because that could increase, stimulate increased energy production, stimulate increased maybe detoxification. That's something you don't want to be doing through the pregnancy. And is that in itself maybe something that triggered a miscarriage aspect? So, there's certain nutrient demands that you want to do to maybe preserve methylation to kind of handle the body or handle that process a little more effectively. But then also too, when it comes down to some of these advanced concepts, that deal with, like back to the iron side of things, I'd probably say, 8 out of 10 of the fertility cases I work with, the iron story is a big factor. And usually the only thing that's being checked is like a hemoglobin level on these women every maybe couple of months. And so my biggest thing is like, doing a full iron panel, maybe every 6 weeks, every 8 weeks at the minimum through this process, to make sure that as the demand changes on the body through the pregnancy, are we helping support the iron regulation a little more effectively? Because there's a real fine line where iron can get a little bit lower, a little bit high, based on whatever you're doing or the demand on the body, and that can drive certain inflammatory processes in the body that can just start to wreak havoc in terms of how mom feels, and could be a component that maybe triggers a miscarriage in the process. So through the there's certain nutritional demands that are there, but I think monitoring, understanding each woman's individual genetic predisposition on what are some of those foundational components that need to be really monitored or addressed. And so what I see a lot of times is the fertility case I work with, once they get pregnant, we are really keeping our eye on things like iron regulation through the process, because that is something where maybe they've been anemic their whole life, or they were really anemic during the pregnancy, and it's something that has to be addressed to be able to carry the pregnancy full term.
So, okay, and to elaborate on that, what we're teaching in this MTHFR course is, let's look at these top 5 or these top 10 or these top 15 genes. I mean, literally you could have top 25 genes, but as it relates to pregnancy, we're looking at how well iron is being transferred into or out of the bloodstream, and mostly away from the GI health, so that we don't feed pathogens, and we're able to allow these energy pathways to produce SAMe and to produce creatine, and to be able to repair your DNA and make a baby in the belly and give the insights without pushing it too hard. So there's lots of hope. Let me ask you this.
Yeah.
Curious, how many women have you helped go full term in your practice so
far? You know what, to be honest with you, it's so funny you asked that, because probably about a month ago, me and my staff were talking about that, and really it's something that we want to go back and now can actually get a statistical kind of component with that. But here's the thing: is it's like more often than not, the patients we're working with go through, when they get pregnant, and go through a full pregnancy, which is great. Every once in a while there's a mishap or their miscarriage, but it's like, more often than not, it's like, it's very exciting and very enlightening for, these females to finally get pregnant or carry that pregnancy full term, because there are some things we kind of fine tune and really address more specific for them, through the process, rather than kind of putting them in a one size fits all from a prenatal supplement and, hey, we're going to check your vitamin D and your thyroid. There's so much more to that in this process. So exact numbers, I don't know. It's funny because we were talking a month ago about going back and actually being able to count up that, but like I said, I do see a lot of fertility cases, probably, 1 or 2 a week. Wow. And so it's very exciting. And here's the thing, which is great. A lot of the fertility cases I see are not a lot of the miscarriage components, which I see that, but I see more and more of people that can't get pregnant. Okay. And having problems with the conception aspect. And so what's really, really cool is we start addressing some of these things, and then it's like literally like in, a few weeks time, 2 months time, I get the email, I'm pregnant now. What do I keep doing? Like what supplement, like what's in my protocol that's got to change now going forward? And those are great emails to get. And we get those all the time.
That's awesome. So do you tell your wife? Does she get upset when you said I made another lady have a baby, or is she?
Yeah, she does. All like it's an ongoing joke. I can remember the first time that happened. It was literally probably maybe 5 years ago, and I called up and I'm like, "Hey, Tara, I got a patient pregnant." It was like, "What?" But now it's kind of an ongoing joke. Hey, we got another patient pregnant. It's awesome, And so because the thing is like from the genetic standpoint, as Joel, it's like I kind of really resonate to the genetic aspect because me and my wife did have fertility issues, and this genetic information, she has 3 MTHFR mutations, she's got some issues with, other factors that deal with histamine issues, so it's kind of really near and dear to my heart in terms of the fertility aspect, and then as well as now transpiring into the kids on the spectrum. But, I do have a kind of a personal, kind of passion and kind of mission with the fertility cases that I see, because there's limitations out there, and the thing is how much do some of the medication components and everything else that some of these women have to take during pregnancy is adding to their toxic load, but also the toxic load of the little one developing, and how does that play into neurodevelopment issues. So there's kind of a different mindset. There's different things to look at from a standpoint, and knowing the genetic picture and where some of these kind of genetic mishaps can happen that are very common through, recurrent miscarriages or other fertility where there's issues with conception, things of that nature. It's very powerful to have that information, those tools to be able to take a different approach that is, pretty successful.
Yeah, very successful, and it's just amazing, and that's why I wanted to again jump on the call, John. Like as soon as I had this appointment today with this patient, I said, okay, I got to talk to John today, and we'll do a Facebook Live, because when we put together the MTHFR crash course, there's so many where someone is a great candidate to take the program, someone who has reoccurring viral infections, someone that has histamine reactions and a lot of pain and bloating and allergies, but also the health of the unborn child, and being able to conceive and being able to gestate for the entire pregnancy without miscarriage is an ideal candidate for someone to take this program. So just make sure we'll put the link under the Facebook feed. And I don't see any questions. I see a couple people watching. Jenny, I hope you're well. And Michelle, I hope you're doing well. I ended up emailing you not too long ago, and I just hope you're doing well. Send me back an email and let me know how you're doing. And those are actually, John, so what we'll do tomorrow is we'll do the histamine one. And then I was thinking probably it'd be a good idea to talk before the end of the week about the whole biopterin cycle, where you get mood disorders and anxieties and depressions and compulsions and addictions. That's a huge area that we can touch upon, maybe from the superficial side of things, but really explain how the MTHFR crash course would really be a great primer for those people. So,
yeah, absolutely.
Anything else you want to add on that?
No, you caught me perfect timing to hop on. I had a few minutes to get on this, and tomorrow I'm going to kind of go through a case study that kind of really connects the dots on that histamine story in terms of how the labs kind of reflect the genetic aspect that reflects the symptoms, and really kind of tie that story together. And then, we can do something on bioptin and bioptin recycling, and how that can, affects mood components like anxiety and depression issues. And here's the key thing with that. It kind of goes back to the iron story as well. So we'll tie that in too. All right.
Awesome. All right. Go do what you got to do, and I'll talk to you tomorrow.
All right. Sounds good. Take care.
All right. Take care.
Bye.
Bye.